Hi, it's Cindy here, creating another piece of Shockwave educational content. The purpose of this recording is to summarize some key points in the 2022 paper by Ryskalin et al. Titled Molecular Mechanisms Underlying the Pain-Relieving Effects of Extracorporeal Shockwave Therapy, a focus on fascia nociceptors, and to integrate some thoughts on the effect of focused shockwave and nociception in our veterinary patients. This paper delves into the effect of shockwave and fascia. Fascia is a very exciting topic. The paper is mostly based on human literature. It covers a good review of current literature on therapeutic shockwave, both the effects of therapeutic shockwave and the mechanisms of action. It also discusses different types of shockwave devices, and then delves into the human fascial system. Finally, there's a connection made between the pain-relieving effects of shockwave therapy and the large amount of nociceptors within the fascia. Read the paper. It has a lot of great information. Today, I'm going to focus on the effect of therapeutic shockwave on pain originating from fascia. The original work on pain relief from shockwave therapy is mostly on the effect of shockwave on acute and chronic injuries of the musculoskeletal system. So we're looking at the musculoskeletal system that encompasses bones, joints, muscles, tendons, ligaments. This system provides the body structure and enables movement. What does fascia encompass? Fascia is a network of connective tissue that surrounds and supports structures in your body, including muscles, bones, organs, nerves, and blood vessels. So fascia is within the body, surrounding all of our different muscles and organs, nerves. And originally, fascia was thought to be structural, to hold things together. But now we know more, and it is not just a structure, but it is an important organ that has a lot going on within it, and we don't want to just ignore fascia. Fascia is divided into superficial and deep fascia. These types of fascia are definitely distinct. They serve distinct but complementary roles in our anatomy and health, with superficial fascia insulating and cushioning, while deep fascia can stabilize and sense. While both are important, we do want to recognize that deep fascia is now becoming a player in chronic pain, especially when there is mechanical dysfunction and inflammation in and around the deep fascia. Superficial fascia lies right beneath the skin, nestled between the skin, the dermis, and the underlying deep fascia. Superficial fascia is composed of a mix of collagen and elastin fibers. They're interwoven within adipose tissue. This fibroelastic layer does have several important roles. It serves as insulation. So superficial fascia surrounds fat cells and regulates the body temperature. It's a place for storage. Superficial fascia stores a reserve of both fat and water. It helps with mobility. Superficial fascia will loosen the architecture and allow the skin to glide and structures to glide under the skin. Sliding flexibility and shock absorption is part of the function. And finally, superficial fascia is a connection between the skin and the deeper muscular skeletal tissues. Interestingly, though, superficial fascia isn't inert. Like I said, it does contain fibrous and elastic fibers, fibroblasts, immune cells. It is innervated with nociceptors, although not as many nociceptors as the deep fascia. Superficial fascia does contribute to our somatic awareness when we touch and feel things on our skin, and does play a role in pain syndromes, especially when there is an alteration due to trauma or systemic inflammation. Deep fascia is becoming fascinating. Deep fascia is denser, it's more fibrous than superficial fascia. It's going to envelope muscles, bones, nerves, and blood vessels. Anatomically, it forms a multi-layer sheet of collagen-rich connective tissue, and it's going to have layers separated by connective tissue that's rich in hyaluronic acid. So there is a gliding ability between the layers of deep fascia. Deep fascia truly has a ton of sensory innervation. According to research summarized in this paper, deep fascia is heavily populated with free nerve endings. It has a lot of unmyelinated C fibers and thinly myelinated A delta fibers. These neurofibers are critical for detecting noxious mechanical stress, chemical changes like inflammation, and thermal stimuli like heat in your muscle and other deep areas of your body. The sensory input plays a direct role in pain modulation, making deep fascia a prime suspect in certain clinical conditions seen in humans, especially myofascial pain syndrome. So, evaluation of and for relief of fascial pain has become an important topic in human medicine because of the prevalence of this myofascial pain syndrome. Myofascial pain syndrome causes chronic pain, and it does affect both quality of life. It does affect the quality of our life, and it can be debilitating. Myofascial pain syndrome can be defined as a chronic pain disorder caused by irritation and dysfunction of the myofascial tissues. So, what are some key characteristics of myofascial pain syndrome? Trigger points, pain, muscle stiffness, and weakness. Trigger points are persistent in myofascial pain syndrome patients. Trigger points are hypersensitive, palpatable nodules located in top bands of skeletal muscle or fascia. These points can cause localized pain or referred pain. Pain, pain is often described as deep aching or burning, and may worsen with use of the affected muscles or stress. So pain is part of the myofascial pain syndrome. That's the pain that's perceived in the brain. Muscle weakness and stiffness. In myofascial pain syndrome, patients tend to have chronic tension in the muscles, and this chronic tension leads to reduced range of motion, muscle fatigue, and stiffness. How can therapeutic shockwave help relieve our human patients with myofascial pain syndrome? There are multiple proposed pain relief mechanisms that could be specific to fascia. These include degradation of fascial embedded nerve fibers. Deep fascia, we have mentioned, is innervated by C and A delta fibers, as well as free nerve endings. Shockwave therapy can selectively degenerate these fibers. It particularly degenerates C fibers, and we know C fibers are responsible for chronic pain. Shockwave will reduce the nociceptive input from the fascia and thus continue long-lasting analgesia. Reduction of substance P and CGRP in fascial nociceptors themselves. Fascia contains nociceptors. Substance P and CGRP are key players in getting the nociception signal to the brain. Shockwave reduces the presence of these neuropeptides within the fascial nerve endings and the associated dorsal root ganglia. This will lead to decreased neurogenic inflammation and decreased pain signaling from the fascia. Reduce the neurotransmitters, less pain is perceived in the brain. What about reinnervation? We mentioned that shockwave can degenerate the nociceptic fibers. There is also a reduced potential for them to reinnervate in the fascia after shockwave therapy. Lack of reinnervation helps lower pain sensitivity. Finally, mechanical disruption of fascial adhesions and trigger points. It's clear shockwave exerts mechanical forces. We disrupt the dense or fibrotic fascial layers. It disrupts myofascial trigger points and restores gliding mobility, reduces tension, and relieves mechanical irritation. Here we have proposed mechanisms of pain relief that produce an analgesic effect on fascia. It's targeting nociceptive nerve fibers, inflammatory neuropeptides, and mechanical dysfunction. Much of the literature on the effect of fascia pain and shockwave is based on myofascial pain syndrome studies in human patients, evaluating pain in human patients based on their pain scores. But in animals, there is no simple, objective, quantitative method to measure pain in all situations. Animals can't just tell us their pain level. We can't ask them on a level of 1 to 10, what's your pain? How do we get by with this? How to relate fascial pain to animals? One study I want you to think about is a study from 2020 on equine back pain, where she was able to quantify thoracolumbar back pain via mechanical nociceptor threshold measurements. Found that the analgesic effect of shockwave was sustained across 3 shockwave treatments that were delivered 2 weeks apart. And the pain relief lasted for another 14 days after the 3rd shockwave session. Here we're looking at muscle pain that's relieved over a long period of time. The other interesting fact was in this study, there was no change in the cross-sectional area of the muscle, suggesting there wasn't a lot of change in the muscle physiology itself. Perhaps this was a good example of the effect of shockwave on the fascia. Does myofascial pain syndrome exist in our veterinary patients? Don't know, hard to guess, but we have all seen amazing cases where patients are dramatically improved for a long period of time after a few shockwave treatments on their myofascial tissue. Have you considered the amount of fascia you are treating? What fascia is in the focal zone when treating different common conditions in our veterinary patients? This is an interesting topic to ponder and explore. I'm sure we will have more information in the future, but it's an exciting topic and something that could greatly benefit veterinary patients. The difficulty in veterinary medicine is they can't verbalize a pain score, so we need to be creative. I hope this entices you to think a little bit about the fascia as you treat common conditions, even your stifle joint. What about your tendon that has fascia surrounding it? So it's something for us to think about. I hope you enjoyed hearing this, and please take the time to explore this 2022 paper on fascia and nociception. Thanks so much.